What I'll do is I'll take you through what is happening to newborn health globally and also in context to our country. Now, you can see that majority of the deaths, newborn deaths, almost 65% of newborn deaths are actually occurring in only 10 countries. And Pakistan contributes as one of the significant country towards the neonatal mortality, and is the third highest neonatal mortality rate globally. So now I put this slide up because we know now that where do we need to focus. So we need to focus on South Asia and also Sub-Saharan Africa, the two regions of the world that are challenging in context to neonatal mortality. Now, if you look at the Pakistan neonatal mortality, it was somewhere around 50, rovering around 40 and 50%. But as of now, 2021, it stands at 40 per thousand live births, which is still very high. Our national annual rate of reduction is around 2.1%, while we need approximately 12%, which is about at present, we are 5 times less than what is required to reach the SDG global targets for the SDG 3, where the target is to bring down the neonatal mortality globally to 12 per thousand live births. Now, we talk a lot about causes of death, causes of neonatal mortality that are, focused around care, health system care, care around medical needs of individuals and populations. But we know now that there are other major contributors towards the neonatal mortality, and some of them are very important in context to the socio-demographic factors, challenges, economic challenges, poor healthcare infrastructure, lack of trained, skilled workforces, and the quality of services. I bring in this insight because within the country, like Pakistan, there are different challenges and not all interventions work in the same way, having the same impact. Now, this is a data that I would like to share with you to show that there is the United Nations IHME data, which tells us about the neonatal mortality in the country and the child estimates. This particular study that we did, this was a project in 2022, and it's the VASA project, we call it, Verbal Autopsy and Social Autopsy, which is a method by which we can ascertain the cause of death. So this particular population-based ascertainment of death project entailed looking at approximately 0.7 million households, which were actually targeted in this particular project, had a total live births of 0.5 million, and had a neonatal mortality death of almost 20,000. So when we looked at this population-based data, we found that the neonatal mortality remained the same, approximately 40 per thousand live births, and the infant mortality, which was initially high, and the under 5 mortality, which was hovering around 95 per thousand live births, was better, but the neonatal mortality was stagnant, whether we talked about Pakistan Demographic Health Survey, whether we talked about this live population-based data that we did this entire survey in all the provinces of Pakistan. So our mortality is stagnant. Now, if we look at what is happening to the causes of death, and I think it's important here because when the 2020 Pakistan Demographic Health Survey was done, and the verbal and social autopsy later on in 2020 and 2022, there is not a huge difference in the causes of death. Birth asphyxia is perhaps the highest, cause of neonatal mortality, and we know from evidence that interventions that are within the 24 hours of birth will save approximately 1/3 of mortality. And you can see here that the causes of death still remains birth asphyxia, infections, sepsis, meningitis, complications of prematurity that lead to deaths, pneumonia, congenital anomalies, but the major chunk is around the 3 causes: asphyxia, infections, and causes due to prematurity. Now, if you look at where do these newborns die, and within the WASA, there were approximately 55% of deaths were actually occurring in hospital, and about 40, around close to 40% at household or in the community, while a small number of around 5 to 6% were either in other health providers or community health worker houses or en route to seeking care at a facility level. And if you look at the Pakistan Demographic Health Survey across the 2 decades, you can see the proportions are almost the same. The blue bar is the blue line is the one which is showing delivered in health facility, and the red one at home. So what you can see that over the 8 years, there hasn't been a major difference. What has happened, although, is the health facility deliveries have improved, not necessarily the neonatal mortality. And if you look at the timing of neonatal mortality, we know majority of the deaths occur almost close to approximately 50% of the deaths would occur within the first 48 hours and the remaining within the first 7 days. So interventions that are required have to be within the 24 to 48 hours after birth, at the time of birth, if we are going to reduce the neonatal mortality. Now, a bit about regional data and context, because Shaun is going to talk about the iNCK trial. So this is basically just showing you how Central Asia, Pakistan, and the northern area of Pakistan, which is known as Gilgit-Baltistan and Chitral, the geographic terrains, these are areas which are difficult terrains. They are harsh weather, high altitudes, lack of infrastructure, and here are where our mortality rates are very high. So this particular map shows you the Gilgit-Baltistan area with its province, with its districts, and within this is a Pakistan map. And if you can appreciate the orangish Gilgit-Baltistan, this is the area where we have a high neonatal mortality rate. And we have some recent data from this area where we can see that the institutional deliveries across the years from 2017 to 2022, and these are 3 different sources, where you can see that the institutional deliveries, they tend to be higher as compared to previously, but still, if you look at some of these districts, Astor, if you can look at the Astor and Skardu, there are still high levels of community-based delivery or household deliveries, leading to high rates of neonatal mortality. So where are the gaps? What's happening? Why are we not moving? Why the neonatal mortality is so stagnant? So as I previously spoke about, we recently concluded a newborn case study for Pakistan, and hopefully we'll be publishing it soon in the Lancet, where we looked at what is ailing the Pakistan health system. And when we looked at some of the determinants, we found that there were many, but what was important was birth interval, family planning, birth order, age of the mother, education, and of course, wealth. The poorest quintile had the highest rates of neonatal and stillbirth mortality. So health within itself would not improve by interventions that are direct towards health system, but it also involves a mindset change, community involvement, community mobilization, access to care, and improving the poverty line of these vulnerable populations. So some of the important determinants that we looked at were poverty, air quality, literacy rate, and access to information. Some of the major determinants that would have an impact on both maternal and newborn mortality and health in general. The other maternal factors which are absolutely important in context to newborn survival, because mother and newborns are interconnected and cannot be separated. A healthy mom and a healthy pregnancy leads to a better outcome. We all know this. However, in Pakistan, excuse me, anemia is found in almost 42% of women between 15 to 49 years of age, And this is from the National Nutrition Survey that was conducted in 2018, of which iron deficiency was almost 50%, short birth intervals less than 2 years, 37%, and other determinants which we tend to look away or we tend not to talk about them is emotional and physical partner violence. So what are the bottlenecks? Like many LMIC countries, we face similar bottlenecks. But I think what is more important in terms of Pakistan is that there's such a diversity among districts, among the provinces, that there are provinces which have better health financing, they have better HR, while others do not. And in context to what we'll be hearing from Shaun, we will be talking about in those areas which are difficult terrains, where there is poverty, where there's access to health is a huge challenge. Now, this is recent data that we've from 2019 that we've looked at the postnatal care for mothers and newborn, and some of the interventions that we know work in real life. The postnatal care visits for the mothers and newborns are, say, less than 50%. Use of skin-to-skin contact, or what we call as kangaroo mother care, is almost non-existent. Breastfeeding within 1 hour, that is an absolute protective impact on the newborn survival, is low, and so is the cord cutting or the clean care or clean care, sterilized care of the umbilical cord. So what has been the gains over the years? We have seen, in this newborn case study, we looked at literature and published literature, gray literature, surveys, policies that have been done. And we've noticed that there have been some gains in terms of antenatal care, in terms of facility birth, in terms of early initiations, but the gains have been small and they've been very slow. And the coverage is still very low. And as you can see, these are some of the indicators that you, especially if we look at the postnatal visits, there is some improvement and then a decline and a plateau. Now we know there are 3 main causes of newborn deaths that have an impact, and if we are able to provide them, such as the use of antenatal corticosteroid and preterm labor management, essential newborn care, including kangaroo mother care and immediate kangaroo mother care, birth complications, preventions by skilled attendant and obstetric care, essential newborn care in terms of basic resuscitation, and in neonatal infections, absolutely important, essential newborn care, breastfeeding, use of chlorhexidine where appropriate, and case management of neonatal sepsis with antibiotics, and the role of IPC. About 71% of newborn deaths are actually preventable, and without going into the intensive care. There is this concept that LMIC countries lack in health infrastructure and they need more neonatal critical care unit. Well, the reality is, if we are able to provide essential newborn care that is close to their homes, we will potentially not need critical care units. Their utility and their presence is important, but it is for a very small population of the newborns that can be saved. So in context to what needs to be done, there has to be a community component in addition to a facility-based component in order to save these newborn lives. So interventions, these are some of the interventions that are all evidence-based. They have huge impact, and if they're delivered around the time of birth, the chances of averting newborn deaths is high. However, we require a high coverage of care in order to have an impact on the mortality outcomes. So what are those interventions that have been tested, and there have been low-cost interventions, and they've been tested in the forms of trial. So one has been the use of chlorhexidine. It reduces neonatal mortality by 23%, reduces omphalitis, and then reduces sepsis secondary to omphalitis. The second is the use of clean delivery kit. It reduces neonatal sepsis, prevents postpartum sepsis, puerperal sepsis, and leads to better maternal and newborn outcomes. Use of emollients. Now, the use of emollients in Pakistan is a tradition that has been there for ages. And no matter whether you're residing in the rural areas or the urban areas, the use of emollient as a traditional practice is considered, is something that has been there. And the thought process is that it improves the muscle mass, it improves the weight, it helps the baby in the neurodevelopment, and it also keeps the baby away from infections. So we know from studies now that sunflower oil and coconut oil have an improved outcome on sepsis as well as weight gain. Thermal management, we know that kangaroo mother care is an intervention that reduces neonatal sepsis by 50%, neonatal mortality by 30%. And there are other methods to check the hypothermia impact at a community level. And Shaun is going to talk more about this. So I'll skip to the next one. In Pakistan, one of the problem has been we are unable to register the birth weight. The rates of birth weight recording is as low as 20%, 20 to 30% across the provinces. And we are aware that low birth weight itself is a high risk, and it increases the risk of mortality by 12 folds. And in order to ensure that these small, vulnerable newborn babies receive the right care, it is important to record the birth weight. So keeping all these interventions in mind, a trial was designed. This was way back in 2020. And what it did was it packaged the newborn in a sort of a community-based package. And the delivery was at the household level. And what it showed was that it was a large randomized controlled trial. And it was a cluster randomized controlled trial, and we saw that it had a huge impact on the neonatal mortality. In the control arm, the newborn mortality was more than 50%, while in the intervention arm, it was close to 40%. And the deaths within the first 7 days of birth were reduced by 25%. Now, this is contextual evidence showing at a population level in a controlled environment what works if it is implemented at a community level. Now, this study was done in Rahim Yar Khan, and if you can see the map, the red area is the Rahim Yar Khan. It is a district within the province of Punjab with a high population, high density, rural and urban population, and you can see more urban population than rural population, low literacy rates, males being more literate than females, and a gender ratio of about 60 to 39 with a high male gender ratio. This was a trial that was published in 2024, and it showed that the impact of maternal and newborn care service packages on perinatal and newborn mortality, published in JAMA. Now, this was followed by another trial which we did with SickKids, and we collaborated with Shaun Morris and Lisa from SickKids. And we looked at, and Dr. Putta from the SickKids Center of Excellence in Pakistan and SickKids Global Health in Toronto. And we looked at what an integrated neonatal kit would look like. This was based on the earlier study that I showed you on the perinatal neonatal mortality, and this was then done in a different terrain. And we looked at what impact would an integrated neonatal kit would have on specific neonatal mortality in Pakistan. And this trial was also in a similar pattern, and I will not go into detail because Shaun is going to talk something about it, so I'll leave the context, the details of this trial with him. But it also showed that an integrated neonatal care approach it reduced the cause-specific neonatal mortality in rural Pakistan. So there are a few messages that we have learned, and we need to take them forward. Maternal and newborn care cannot be separated. We have to have interventions that are interconnected with the mother, and earlier in pregnancy, earlier more in adolescent age, and then in pregnancy, and of course during the delivery, the perinatal component, and the immediate postnatal period. We cannot say that it's only facility-based care that will save these vulnerable newborn lives. Of course, facility-based care is definitely needed, but it requires huge resources. So we have to be innovative and consider innovations that can potentially be implemented within the existing health infrastructure, within the health system, and they are closer to the families, closer to their households, and these can be implemented earlier so that complications on the perinatal periods are reduced. Do we have evidence? We do. We have rich and robust evidence, and it is as well, it is not only rich and robust, but it is contextual as well, and it is evidence based. So we do have the evidence with us. What is needed is scale up, and scale up is a huge challenge, but that is something that we need to do. Scale up these interventions, connect them to a good referral pathway to a health facility, and have the scale up to have measurable and meaningful outcomes in order to prevent not only neonatal mortality, but also have safe mothers, safe pregnancy, and safe childhood.
And so with that, I'll be spending the next 25 minutes speaking about two trials that we have done that have that build directly on what Shabina has just been speaking about. So the objectives will be to, number one, describe the methodology of the iNCK, which is the Integrated Newborn Care Kit Cluster Randomized Trials. Two, so one in Aga Khan, which is the study that Shabina was just referring to at the end of her presentation. And the second, more recent one is in Gilgit-Baltistan. We'll be talking about the lessons learned and the results of the Aga Khan study and how we incorporated these into the larger study in Gilgit-Baltistan. The picture on the right is the Karakoram Highway. So this is the highway that goes from Gilgit, which is the main city in Gilgit-Baltistan, up to the border with China. It is a stunning part of the world. It's an honor to be able to go there and to work there. But as you can see from the geography, it's also a very challenging place, unsurprisingly, for people obtaining healthcare. So I think one of the take-home messages from Shabina's talk is that to prevent newborn deaths, interventions are needed that span the facility to community landscape. What I'll be focusing on are interventions that are community-based, effective, low cost, and potentially scalable, which, as Shabina said, is truly the most challenging aspect of any intervention and taking the science to being used in real life. So the rationale behind the Integrated Newborn Care Kit study is that effective and sustainable interventions are needed to improve newborn survival, and that these should be studied under pragmatic, real-world conditions, effectiveness trials within existing local health infrastructure. And Shabina mentioned this, and it's an important concept that I'll come back to throughout my talk because it is an essential step, I think, to have a feasible pathway to incorporation within the healthcare system and to scale up. And so the idea was a trial of an integrated collection of simple interventions to reduce major causes of newborn and maternal mortality and morbidity in community settings in low and middle income countries. So the solution that we wanted to study is called the Integrated Newborn Care Kit, or iNCK, as I'll be calling it in this presentation. And the principles behind the kit are on the right-hand side, which I'll walk through quickly one by one. So number one, each of the components that we wanted to put into this integrated kit needed to have evidence behind them. And Shabina has presented some of this evidence already. But at a high level, we wanted to make sure that each component did one of the following: either reduce newborn death, or reduce infection, or provide early warning that there's a problem, and then the family could seek care earlier than they otherwise would. Number two, it needs to be portable. And this gets back to something else that Shabina said, that most of the deaths are happening in the first few days of life, and many of them are happening in remote areas that are quite distant from healthcare facilities. And so we wanted our kit to be in the hands of a family when the baby was born, which meant that it needed to be delivered to them when they were pregnant in their home. It needed to be easy to use. So the concept behind our kit is that for the most part, the different components are being used by family members. And so it needed to be simple to teach and to use by these individuals. And it needs to be low cost. So clearly, to have a feasible pathway to scale up, it needs to be affordable for different contexts. And so our goal when we designed the kit was to keep the price under about $5. And finally, integrated. This has several meanings. So one, I wanted it to be integrated along the prevention of problems to the identification of problems to the treatment of problems pathway. We also wanted it to be integrated across the maternal and newborn dyad. So what is in the iNCK? So number one is a clean delivery kit, which Shabina mentioned. A clean delivery kit itself is essentially a kit within the kit. So it has gloves, it has soap, it has a sterile plastic mat that can be laid down on the ground so that the baby can be born onto something clean, regardless of where the place of delivery is. And it contains sterile cord clamps and a sterile blade. 4% chlorhexidine gel. So Shabina also touched on this, that there's evidence that this can reduce both umphalitis, so infection of the stump, as well as reduce newborn sepsis and improve newborn survival. So mothers and caregivers were taught to apply chlorhexidine to the umbilical stump once per day for the first 10 days of life. Number three, sunflower oil emollient, which Shabina also presented some of the evidence for. So it strengthens the skin barrier, it improves infant thermoregulation, has benefits in regards to weight gain and also reducing infection. And caregivers were taught to apply this to the newborn's body once daily from the first day of life to the 28th day of life. And I should say that in the places that we were working, it is a traditional practice to use an oil emollient. It's typically a mustard seed oil, which has not as favorable properties as sunflower oil in the fact that it can cause a little bit of breakdown of the skin barrier on a microscopic level. And so we're substituting out a more favorable product, but maintaining the traditional practice. ThermoSpot is a sticker. So the audience may not be familiar with this product. It's a sticker. It's the size of about a small coin, and it's embedded with liquid crystals. And these liquid crystals change color based on temperature. And the mother is taught to apply the sticker over the baby's carotid artery on the neck. And essentially what it does is it's a continuous temperature monitoring device that says if the baby is a normal temperature, is too hot or too cold. And this is what ThermoSpot looks like. So it's a pale green with a normal temperature. It's a darker green with a normal temperature. Pale green is cold stress or mild hypothermia. And the instructions to the mother are that if the baby is a little bit hypothermic, to do kangaroo care, which you just heard about, has excellent evidence behind it. If the baby is more hypothermic, as measured by ThermoSpot, the mother was taught to wrap her baby in a mylar blanket, which is a reflective material that maintains heat very well, and to activate a click to heat warmer. And what this is it's a little pouch that has a liquid sodium acetate solution in it. And when a metal disc is flexed, it changes the liquid sodium acetate to solid form, and it's an exothermic reaction that releases heat. So basically, the baby is wrapped in a heat reflective blanket, a little warmer is activated, put into the blanket, and then the mother is taught to take the baby to healthcare. Finally, if ThermoSpot indicates a fever, that's another indication that the family needs to seek healthcare. Shabina mentioned that very few babies, in particular in remote parts of Pakistan, are weighed, and this is obviously an important gap because understanding a baby's birth weight can initiate different preventative practices, be it related to nutrition or other additional monitoring. And so we did not include a scale within the kit itself, but we did support the community health workers who delivered the kit, and I'll mention who they are in just a second, with a handheld scale so that all of the babies in their catchment area could be weighed at birth. So who delivers the integrated newborn care kit? A group of community health workers called Lady Health Workers. And Lady Health Workers, or LHWs, are a government-supported community health worker program that exists over much of Pakistan. And our effort in the trial was to really to use this amazing group of workers and disrupt their daily activities as little as possible, because we really did want it to be a pragmatic, real-world effectiveness study. LHWs already, as part of their daily work, identify pregnant women in their community, and then we ask them to notify the study team. There is a routine visit of LHWs in the third trimester of pregnancy to pregnant women, and we use this visit to deliver the integrated newborn care kit. And It was the LHW who actually provided the teaching around how the kit is intended to be used. So I'm going to talk about some of the results from the Rahim Khan study. So Shabina already showed you where Rahim Khan is in the south of Punjab. It was a cluster randomized trial where the unit that was randomized were villages. So essentially it was the villages and the LHWs that work within those villages. We randomized 150 clusters, half to receive the intervention, which is the iNCK, half to receive the standard of care. That was the control arm. And this study was done now about 10 years ago. In total, there were 5,451 pregnant women who were enrolled. The primary objective was to determine the effectiveness of delivering the iNCK by LHWs and educating pregnant women and their families on its use on newborn mortality. So the trial procedures are shown here. So the LHWs identified pregnant women in the third trimester. We then enrolled, with consent, the family into the mother and the family, the household, into the study. And the LHW then delivered the kit in the third trimester of pregnancy. And so it could have been delivered anytime from the beginning of the third trimester to the end of the third trimester. And this is important when we talk about how well the kit was used. So there was a large period of time over which the kit could have been delivered. Soon after delivery, there was a birth notification that we had sent to the study team. And then there was intensive data collection in person at the household on days 1, 3, 7, 14, and 28 after birth. So 5 data collection visits after the baby was born. If a death occurred, we did a verbal autopsy, which was also alluded to in the prior talk. So this is essentially a standardized list of questions around the signs and symptoms that were present leading up to death that we can use to try to determine the cause of death in the absence of a vital registration system or a medically certified cause of death. The primary outcome, as I mentioned, is newborn mortality, so death from any cause amongst a live-born infant in the first 28 days of life. Key secondary outcomes were umbilitis, or infection of the umbilical stump, severe infection, defined as you see here, and the proportion of babies that had a measured birth weight at birth. So of the 5,451 women who were enrolled, there were 5,233 live-born newborns who had a complete vital outcome. So we knew their alive or dead status at the end of the first month. And you can see here the delivery characteristics. 60% were delivered in a facility, 50% were physician attended, about a quarter were delivered via C-section. You can see on the right-hand side the characteristics of the newborn, including the sex difference, the gestational age, and the mean birth weights. And there were no key differences in the baseline statistics between the trial arms. So what did we find? So the first thing is that the uptake of the integrated newborn care kit in terms of the individual components was very high. And what I mean here is, was it used? Yes or no, like in a binary fashion. So 92% used the clean delivery kit overall, including 95% of home births, and 99% used chlorhexidine, the oil, and thermospot. So this is great. The uptake overall was very high. However, when we dug into the stats a little bit more, what we found is that they were often not used correctly or as intended. And this, in retrospect, I think makes a lot of sense. So as I said, the kit could have been delivered and the mom received teaching at any time during the third trimester. So it could have been days to a couple of months before she had her baby when she received the kit and she received teaching, a single teaching episode about how to use a relatively complex multi-component kit. So in hindsight, I think it's not surprising that many of the components, if they were used, they weren't in fact used correctly. And I'll just use chlorhexidine as an example. So it is very important that chlorhexidine be started on day 1 of life because of the figure that Shabina showed, where most of the deaths are happening on day 1, followed by day 2, followed by day 3. So it is important to start in the highest risk period, which means starting on the first day of life. However, less than a third in our study did that. Thermospot did seem to provide value. So 15 cases of cold stress were identified, and kangaroo care was correctly initiated in all of these cases. More severe hypothermia was identified in 11 cases. However, less than 50% did the correct 3 steps of using the blanket, activating the heater, and seeking healthcare. And it was often the seeking healthcare that was not done. 182 cases of fever were identified, and just under 85% of the time, the families correctly followed instructions and sought healthcare. So what did we see with mortality? So in the control standard of care arm, we saw a newborn mortality rate of 30.6 compared to in the iNCK arm, 25.4. So this was a 17% lower mortality rate in the iNCK clusters. However, this was not statistically significant, and we'll talk a little bit about why that may have been the case. In terms of the secondary outcomes, we did see a statistically significant 32% reduction in umphalitis, which is important because this is a major precursor to sepsis and infant death. We saw a 36% reduction in fever in the iNCK recipients. And perhaps unsurprisingly, we saw nearly a 400% increase in the proportion of babies that were weighed in the iNCK clusters. And this makes sense because there quite literally was not a way to weigh babies very often in the standard of care arms. So some of our conclusions from this pilot trial is that the iNCK, though it did not statistically reduce all-cause mortality, there were some important secondary outcomes that we did see significant positive results with. Some of the reasons why we think we didn't see a significant reduction in mortality is that the study was underpowered. So number one, the mortality in the control group was quite a bit lower than we expected. So as you saw from Shabina's presentation, we expected probably about a 40 to 45 newborn mortality rate per 1,000 live birth, whereas in fact in our study we saw a 30 deaths per 1,000 live births, so significantly lower. Part of this we think was because of a Hawthorne effect of being in a study and this really rigorous 5 in-person visits data collection schedule at the home. Also, a very important finding is that although the iNCK uptake was high, adherence to timing of use was suboptimal. Didn't present the data here, but we did a secondary post-hoc analysis where we showed that as compliance improved, so basically as the kit was used more closely to how it was intended to be used, we saw a larger reduction in mortality. And this was an important clue for us that what we really needed to work on was getting people to use the components of the kit better. So we learned some lessons. So lesson number one, despite high uptake, adherence to correct timing of usage was suboptimal. And here again is the chlorhexidine example. So what did we do about this? So in our next trial, what we did is we incorporated a pictorial guide. So we hired a local artist to basically draw out and write out, but the drawing is important because many people, particularly women in the settings in which we're working, are not literate, to explain step by step how all of the components are to be used. And again, this is important because it's built as a one-time in-person teaching at any time during the 3rd trimester. So it's important that we have these memory aids to help people remember how to use the kit weeks or months later. Change number 2, we also had the same artist develop a pictorial diary. So this basically goes day by day and helps the mother and the caregiver to sort of tick a box to say they accomplished a particular task that they were supposed to do on that particular day. This is helpful to trigger people to use the product correctly. And it was also helpful as a data collection tool for us as researchers when we're trying to understand in a more granular way when people started and stopped using the different products. Number 3, we harmonized the start date of all the different products. So for reasons that I won't get into in the original RYK study, we had staggered start points for the different products. And in retrospect, this was probably not a wise idea, and it understandably confused a lot of people. So in our new study, we harmonized and we started all of the products on the first day of life. Change number 4. Following our Rahim Aga Khan study, we did a series of acceptability studies where we were trying to understand what people thought of each of the different products. And it was really clear that people did not like the Mylar blanket. And this is because the material itself was very different than anything anybody had ever seen. And as a result, it wasn't used as often as we would have hoped. Interestingly, it was also the most expensive part of the kit. So if you recall, I told you that the price of the kit was intended to be about $5 and this Mylar blanket was about half of that price. So what we did in our new study is we hired a women-run social enterprise in Lahore to use scrap pieces of cloth and to build these fleece blankets, which were much less expensive and more familiar, and we hoped more acceptable to participants. The next change that we did is you'll recall at the very beginning I said our goal was to be integrated across the maternal and newborn dyad of health. And while clearly some of the components of the kit, most importantly, the clean delivery kit would have benefits to the mom in terms of reducing um, peripartal sepsis, we were not addressing the biggest single cause of death in women, which is postpartum hemorrhage. And so postpartum hemorrhage is indeed the leading cause of maternal death, both globally and in Pakistan. And so the next change is we incorporated oral misoprostol, so dissolvable tablets, into the next iteration of the kit. We also thought that the really intensive in-person 5 times data collection schedule may have had impacts on the overall mortality in the trial, particularly in the control arm. And we felt that in our scaled up study, we in fact did not need such granular data collection. And so we reduced it to 2 time points on day 8, which was by telephone. So it was more remote and hands off. And the idea there was to gather information about the first week of life. And then a second visit, which could be by phone or in person at the end of the first month to collect vital outcome. The next change, also trying to deal with the underpowered aspect of the first trial, was to design a much bigger study. So our first study was just about 5,500 individuals. So we planned a nearly 4 times bigger, more than 4 times bigger study of nearly 27,000 women. So the upgraded integrated newborn kit is shown here, which is different in the sense that it has the misoprostol and the pictorial guides and diaries. And also, I would like to highlight that we were able to source both higher quality and less expensive components for the second version. And this was the price in Pakistani rupees, which is, this is about $3.50 for the components that are sourced in Pakistan. Okay, so I'm going to spend the next few minutes showing some of the preliminary results from the Gilgit-Baltistan study. And I do want to highlight that these are preliminary. We're just in the process of starting to get into the data right now. So Shabina showed you where Gilgit-Baltistan is. So essentially, it's the northernmost administrative district of Pakistan. We did a cluster randomized trial again. Rather than randomized villages, we randomized union councils, which are larger geographic areas and contain several villages within them. This was an effort to reduce contamination, where both physical product and knowledge might leak out of intervention clusters into the control clusters. We conducted the trial between June 2021 to September 2024. And as you heard, our target sample size was 27,000. Here are a few pictures from our study area. So again, I just really do want to highlight the geography that we were dealing with, because this is important, I think, both from the health of the population's point of view, and also just the challenges of implementing a massive community-based study in this geography. We had unbelievable implementing partners with Aga Khan Health Services, a cadre of phenomenal data collectors who live in these areas, and I think really are the true heroes of the study. The picture on the left is a data collection visit that I joined during one of my site visits, and this sort of just gives you the an inkling of some of the risks that the team was always accepting on a daily basis. Just driving around, there were lots of issues related to landslides and problems with entire parts of the study area being cut off in the winter for long periods of time. On the top right is one of the ways in which our data collectors would sometimes cross river valleys. So these sort of like little motorized baskets that they would step into and cross over to the other side. So the objective of the scaled up project was to determine the effectiveness of delivering the iNCK by LHWs again, and educating pregnant women and their families on its use on newborn mortality and other key newborn and maternal health outcomes. Here is the timeline, which I've already described. And the trial procedures are essentially the same as the RYK study, with the exception of the scaled back data collection, which was done on day 8 and on day 29. The main outcome, again, was newborn mortality. And in this case, the key secondary outcomes were, again, omphalitis, the addition of postpartum hemorrhage in the women, and also the proportion of babies that were measured in terms of their birth weight. So we did not reach our 27,000 participant goal. But we did end up enrolling just under 20,000, which I think is still a massive accomplishment in this particular area. And the distribution between the control and iNCK clusters are shown here. The participant characteristics of the mothers are shown on the left-hand side, and the delivery and newborn characteristics are shown on the right-hand side. Just a few things I want to highlight. So 70% were born in a health facility, which is higher than we anticipated would be the case. And down at the bottom right, you can see that the division between boys and girls, the median gestational age at birth, and the mean birth weight, and there were no significant differences, again, between the two arms of the study. So what were the results of this study? So first of all of the components were used at a high rate again. On the left-hand side, you can see the uptake rate in Gilgit Baltistan compared to the right-hand column, which shows the Rahim Yar Khan uptake rate. So essentially, it was the same. It was high across the board. What we did see, which was a huge improvement, is that the adherence to correct usage was far higher in the GB study. So what we're seeing, I think, is that the pictorial memory aid and the diary are really, really an important part of getting people to know how to use this correctly at home. And again, I want to reiterate, it is the family that's using this. Once the family has it, there's no touch points from the study teaching people or reteaching people how to use it. So just using chlorhexidine as an example again, 32% used it correctly on day 1 of life in the Rahim Yar Khan study, 97.4% correctly used it on day 1 of life in the GB study. Misoprostol, overall, 85% of women took all 3 misoprostol tablets at the correct time, which is after the delivery of the baby, before the delivery of the placenta. Let's look now at umphalitis. So in the control arm, there was a cumulative incidence of 21% umphalitis, decreased to 4.3% in the iNCK arm. So this is an 80% relative risk reduction of umphalitis in the iNCK clusters, and this was statistically significant. Looking at umphalitis between those who were born in facilities and born at home, we can see that there was a very meaningful benefit both for babies born at home and, I think importantly, babies born at facilities. Postpartum hemorrhage, so totally new outcome for us. So the cumulative incidence of postpartum hemorrhage in the control arm was 7.7. In the iNCK arm of the study, it was 4.0. So this is a 57% lower risk of postpartum hemorrhage in the iNCK recipients. So we were really super excited to see this preliminary data. For those born at a facility, there was a reduction of 62% postpartum hemorrhage, and for those born at home, a reduction of 55%. And both of these were statistically significant. And similar to the pilot study, we saw a huge increase in the proportion of babies that were weighed at birth in the iNCK clusters, so 186% higher birth weight. And finally, mortality. So this is where we're really going to have to get into the data to understand it over the next few months. So in the control arm, the mortality rate was far lower than we expected, 10.1 deaths per 1,000 live births. And it was 8.1 deaths per 1,000 live births in the iNCK arms. We had a priori determined in our analysis plan that we would be adjusting for the following features that you see at the bottom here. So antenatal care, district, sex, time of the season, basically, baseline newborn mortality rate, and the baseline proportion of facility deliveries. What we saw, one of the things we think that's contributing to this this unexpected finding is that there were some of our districts that had very, very, very small numbers of deaths that were identified. So we actually think that we have some instability in our model. When we don't adjust by district, so this is a post hoc exploration of the data, what we see is that there's a 24% reduction in mortality in the iNCK cluster. So very much in line with what we saw before, but we are still delving into these data to better understand the mortality impacts. In terms of the verbal autopsies that were done, I just want to highlight here that where we did see that the mortality benefit is in the infection and prematurity deaths, which is what you would expect, rather than the birth asphyxia death, because there's nothing in the kit that we would expect to impact birth asphyxia. And in terms of some challenges and limitations, so clearly, we still need to try to understand why the newborn mortality rate overall, including in the control clusters, was so much lower than expected. We had very minimal loss to follow up in our trial. So we had over 99% completion and vital status outcomes for those who were enrolled into our trial. And so I don't think it's related to loss to follow up, but I do think that we did not enroll perhaps the highest risk families, the people who were furthest away and the people who did not have lady health worker coverage, as well as some of the other reasons that we see here. We did have some imbalance between our intervention and control clusters, and we think that this may have had to do with engagement of the LHWs in the two arms. We had fantastic engagement in the iNCK arms, and somewhat less so in the control arms. And so conclusions from the GB preliminary conclusions are that it may reduce mortality, but more work needs to be done. And we're also going to try to meta-analyze the data from our two studies. We are confident saying that it can prevent oopholytis with greater reductions when paired with the pictorial guide and diary. We do believe it reduces postpartum hemorrhage regardless of the delivery location. And we do think that it increases the proportion of babies that are weighed, particularly for those who are born at home. So we have a whole bunch of next steps. As I said, we've just begun looking at the data in the last couple of weeks. So basically the next year is going to be spent doing our full analysis. We are doing a series of qualitative studies of the lady health workers, families, as well as other health system leaders to try to understand how this was received and try to better understand the potential path to scale up. We're doing a health economics sub-study. We're also doing a series of studies related to climate, interestingly, because this is a part of the world that is very, very much affected by climate change. And we're trying to understand how that affects people's mental health and also their ability to access healthcare. And finally, we're having a series of dissemination meetings with different stakeholders in Pakistan, one of which is shown at the top here. This was our meeting in Gilgit-Baltistan with regional leaders from within the healthcare system. So I will wrap up there, and thank you very much for your attention. And I think there's a few minutes for some discussion amongst the group.
I mean, I think we can jump in with these, and then if we run out of things to talk about, I have a very long list of questions that I can ask. But so the question asked by Professor Frand is whether you can give a more detailed description, either one of you, of how the control arm was managing the kind of perinatal phase. And let's start with that one. And I think that that's obviously a very important question also in relation to the concerns about contamination, which isn't the infection type of contamination that you mentioned, Shaun, but in general, when you have a behavioral intervention, then it can be quite difficult to separate intervention clusters from control clusters. So can you describe what the sort of typical control management process would look like?
Shabina, do you want to maybe comment on like what standard of care would be? And then I can comment on some of the specific, I think, important things that we saw in the data that happened in the control arms.
Sure. Yeah, thank you. So basically, when you say standard of care, I think, Rashida, you're referring especially to around cord care, to essential newborn care. Now, in these terrains, although it is standard of care to receive all of this, birth weight, cord care, eye care, essential newborn care components. However, these, because of access, because of the geographical terrains, because of poverty, and because of general knowledge, these were not actually available both in the control groups. However, these are considered standard of care and in facility-based care. They would be present in some portion of the control clusters. But the quality, I think that's an important aspect. The quality and the timing of those essential newborn care is something that is not being implemented, although it is standard of care, but these are not being implemented at facility levels. And therefore, when we say standard of care, we actually mean some of the interventions that you see in the intervention arm would ideally be placed in standard of care in the control arm. Shaun?
Yeah, thanks, Shabina. So a couple things I'll mention. One, we were surprised at the proportion of facility births, in both studies, in fact, including in the control arm. And one of the things is that when one of the concerns we had, and this is something that we had to make sure in terms of our REB that they were comfortable with this as well, is that we wouldn't be disincentivizing or like de-encouraging facility births by providing a physical product. And so we really, really stress the importance of delivering a facility to everybody, regardless of which arm they were in. And so I do think that probably resulted in a higher rate than would be otherwise expected in the control arm of facility births. Second thing I would mention, and Shabina touched on this a little bit in her answer, is I don't have the exact proportion in front of me, but there was a very significant proportion of participants in control clusters that did use topical antiseptics of different sort on the court, and it generally wasn't chlorhexidine, but it was a product called Dettol. And we saw this, we actually saw this in the Rahim Arkan study, which again, remember, was like 10 years ago. We saw this sort of like being incorporated as the study was happening. It was sort of like rolling out in real life. And so that's not contamination in the sense that it was our actual product that was being used in control arms, but practices were changing and standard of care was changing. And as Shabina said, there was variable access to what should be the standard of care, I guess, in the different parts of the control arms.
Yeah, and just to add in, so I wouldn't think there would be an issue of equipoise over there.
Yeah,
Rashida,
I think that goes back to Professor Fran's subsequent comment, and I wonder whether you would agree with the statement that this was really a kind of hybrid implementation effectiveness trial rather than a straightforward trial looking at efficacy. Certainly not, but even effectiveness was basically coupled to the implementation of the kit as a kit.
Yeah, I definitely agree with that.
Rashida,
yeah, go ahead.
Julie, can I just ask, Rashida, do you want to join in verbally?
Yes, sure. Thanks, Gareth. I think I just want to raise this as an issue because it's not about whether we call it a hybrid type 2 effectiveness trial or whatever, but all the components that are mentioned that form the component of the intervention are things that should be standard of care. And I feel that the lack of implementation does not justify them being used as an intervention in the context of a randomized controlled trial. And there is an ethical issue about it being trialed when they are standards of care. I think there is certainly an issue in Pakistan and in other settings where these are not being implemented, including the areas we're talking about, which I'm familiar with. But that should really surely be addressed in trying to improve implementation procedures rather than trial their effectiveness. Over.
Yeah. I mean, Shaun, I think this is the sort of thing that your reviewers are going to be challenging you on. So no bad thing to have an opportunity to discuss that.
Can I respond to Rashida's comment?
Sure.
So Rashida, you very, very rightly pointed out, but I think there are two aspects within the country. In an ideal world, definitely all these interventions, most of them at least, excluding the use of emollient, although some of the HMIC are practicing use of emollient right after birth. But in Pakistan, per se, as standard of care within facility, it's not included. The rest of the interventions are including temperature control, measurements of temperature, and use of kangaroo mother care. But at present, what we tried to do through this trial is looking at, in context to how community-based interventions can be implemented because the deaths are occurring early on. And the interventions, there has to be a hybrid between facility and community and a connection. What we could not, we can't do everything, I wish we could, is to also see how the referral pathways worked, especially in these geographies. So I think these interventions, a community component of interventions most likely needs to go in at least for some time before we really have something like 100% facility birth and quality of care and accessibility and closer. There are areas in Pakistan where you have to walk 6 and 7 hours just to get, do the deliveries, especially in Chitral and Gilgit, and I'm sure you're aware of them, that there is lack of access. And I think the whole idea was, till we reach that time, does this package with the existing health system, especially of the community health workers, can this work in a setting to bring down the deaths in that proportion of newborns who fail to reach the facility delivery? So in all essence, your point well taken, but I think that was one thing we really wanted to see if it would work there. Thank you.
Thank you very much. Shaun, do you want to come back on that as well? Or?
I don't have too much more to add in addition to what Shabina has just said.
Okay, thank you. Julia, there aren't any other questions arising in the chat. Are there things that you are burning to ask yourself?
Well, I mean, I find it a very interesting undertaking, and just to support what Shabina's just said, I think often a trial is a very good way of looking at implementation pathway, particularly if you're looking at a cluster randomized control trial where a lot of people can have access to an intervention in a way that is quite meaningful given the context. So. So I think that often these kind of hybrid designs are a very worthwhile investment. And I mean, I find the observation that your endpoint rate, your primary endpoint rate, was lower than you had expected quite interesting, but also very unsurprising. I have yet to work on any RCT, whether cluster randomized or individually randomized, where the endpoint rate isn't half of what you assumed at the beginning, even when you make very conservative assumptions. So there is something about delivering any intervention in the context of an RCT, the way that it's set up, that I think is obviously has some powerful interaction with healthcare delivery in general. So yeah.
Yeah, thank you. I was thinking back to that cluster randomization of the use of soap in Bangladesh about, it must be 15 years ago. I can't remember whether that ended up with, because that did have very significant results, and whether there was a lot of evidence of contamination in the control arm, I can't remember. Rashida, I'll give you the very brief last word. Because I want Matteo to
I do really think that the point's been missed somewhat, Gareth, in that, a type 2 hybrid effectiveness intervention tests effectiveness as well as implementation. The point I'm trying to make is not about the implementation aspect, but whether there is ethical equipoise when you know that the control, that the intervention that is existing is efficacious. Would you try something when you knew that it worked, like chlorhexidine or something, when you know that it's something all women should have?
Sure, except that, of course,
and I think it's really important to take those,
but
rather than justify lack of distance, etc., as a reason for conducting a trial. Hybrid effectiveness, it speaks to the idea of needing implementation.
Fair enough, but I think the Aga Khan study did not reach significance. So I can understand that there was equipoise at that point, and what's more, the modifications were clearly a step towards a more effective, wider potential intervention. So, but thank you. I think it's really good to challenge these questions, and that's exactly what the aperitivos are for. And I want to thank all of the participants and speakers.